Good afternoon. I'd like to thank everyone for tuning in today, and I'd like to especially thank Dr. Nagaraja and Michael Besser for being my host, and especially the doctor being a presenter today. I just want to let everyone know is that the relationships and the partnership between the University of Michigan and the Michigan chapter of Scleroderma is very strong and very sound. To the point of that last year is that the Michigan chapter funded research for the University of Michigan, which is still ongoing right now. But I want to say is that it's a great relationship and it's one that we're very proud of. So with that, I'm going to allow Michael to do the introductions for the doctor, and then we'll have a nice presentation concerning the effects of kidneys with scleroderma. So thank you.
Thank you, John. I want to welcome everyone to the Scleroderma Foundation Michigan Chapter's web-based educational series. This webinar is being offered as part of our strategic planning efforts to move towards web-based learning experiences for the next 4 years in an effort to reach more patients, caregivers, and family members who are seeking to obtain accurate information about scleroderma. These webinars can reach scleroderma patients and their family members from all over the world, emphasizing the importance of quality educational programming for the scleroderma community. This educational program is made possible in grants from Actelon Pharmaceuticals US Incorporated and Boehringer Ingelheim and the Trico Foundation. And we thank them for their continued support. This webinar, we are presenting Dr. Nagaraja, who will be presenting on renal involvement with scleroderma. Dr. Nagaraja is the clinical assistant professor in the Division of Rheumatology and an active faculty at the Michigan Medicine's Scleroderma program. Originally from the city of Bangalore in India, Dr. Nagaraja received his medical degree from the Renal Medical College. He did 2 years of transitional postdoctoral training in the United Kingdom. He subsequently moved to Tucson, Arizona, where he completed residency in internal medicine and fellowship in geriatric medicine at the University of Arizona. He then completed a fellowship in rheumatology at the University of Michigan in 2014. He became a faculty assistant professor at the University of Toledo and rejoined the University of Michigan Division of Rheumatology in May of 2017. And he is an integral part of the scleroderma program. Dr. Nagaraja brings a unique geriatric clinical experience of chronic care management into the care of scleroderma patients. He is a board certified in internal medicine, geriatric medicine, and rheumatology, and a member of the American College of Rheumatology. His specific research interests include patients' reported outcomes measurement in the rheumatic diseases, including scleroderma, and their implementation in routine clinical care, and the understanding the unique subset of patients with rheumatic diseases who have interstitial lung disease. He leads clinical trials in scleroderma at the University of Michigan in the partnership with Professor Dinesh Khanna. And the Scleroderma Foundation Michigan chapter thanks him for sharing this time to present the webinar and his information today. The Michigan chapter welcomes you and thanks you for your willingness to participate today. Dr. Nagaraja.
John and Michael, thank you. That's really nice to give this introduction, but more importantly, I really commend the effort and the time put in by the Michigan Chapter Scleroderma Foundation in putting this web series together and educating our patients with scleroderma, not only in and around the state of Michigan, but around the country and around the world. That's highly commendable. And it's something that our patients need to self-educate themselves about scleroderma. I always state by saying to my patients that for rare conditions like scleroderma, you are your own advocacy. Patients need to be their own advocates because many people in healthcare and outside healthcare would have rarely heard about these conditions. And then sometimes we just need to educate even many physicians or care teams around the care spectrum. So I was invited to talk a bit about scleroderma and the kidneys. And this is often a not so common topic talked about, at least in the patient education forums. We do talk about quite a bit from a patient care standpoint, and there are publications around, but it's not disseminated in terms of how, why, and where the patients should take care from a kidney standpoint. So I always like to give a brief introduction about scleroderma, the subtypes, for the sake of terminologies. And it could also be that some patients could be watching these educational slides for the first time, and then it would just be a nice brief introduction from what is scleroderma standpoint. So scleroderma is a Greek term that was coined in about 1836 and can be divided into these two words, scleros and derma, basically meaning hard skin. However, it is an autoimmune disease. Our immune system helps in fighting things that are foreign to our body, like infections. They help in keeping things away, but sometimes can turn against our own body. Those conditions that result from that kind of aberration in the immune system is what is called autoimmune disease. Now, auto means self, and of course, immune refers to the immune system. And attacking self is what is the main feature of autoimmune diseases. What's different from what this rheumatologists do is that we deal with a lot of systemic autoimmune diseases. The word systemic meaning affecting multiple organs. So scleroderma is one such systemic autoimmune disease, which not only affects the skin, but can affect the internal organs like the lungs, the gastrointestinal tract, kidneys, blood vessels in the fingers and toes, and also heart, amidst some of the rarer presentations. There are two main forms of scleroderma. The first kind is what we refer to as a localized form of scleroderma. The other one, which we are referring to more and pertains to in this talk, is the systemic scleroderma. Now, localized scleroderma is also called morphia. It primarily affects the skin and is only in only a few body areas. In other words, it's not a diffuse form of skin involvement. Often it tends to be patchy, but it could take a form wherein it can affect continuous areas of the body. Usually localized scleroderma, and I shouldn't quite say usually, but almost always, it does not tend to affect internal organs. Systemic scleroderma is skin plus internal organs. So in the systemic scleroderma family of conditions, you have two broad categories based on how much of the skin is involved, what is the extent of the skin disease. And there, onto the left, is what is called a limited form of scleroderma, wherein the blue areas are the areas where the skin gets affected. So essentially, the face, areas below the elbow all the way to the hand, and knees, below the knees up to the feet. If any of these areas are involved, that's where it tends to be called a limited form of skin involvement. The skin involvement usually starts at the fingers and gradually progresses towards the body. So initially it's the fingers, then the hand, the forearm. That's the usual way it gets affected. In other words, you don't quite see a sudden involvement, say on the abdomen, and then skin being affected in the fingers, and then it being, so it tends to be more from peripheral to central in terms of distribution. Diffuse scleroderma is wherein the skin involvement is really diffuse. It's really more of a diffuse involvement. And the reason I want to focus on these two terminologies is the words or the terms limited and diffuse are only used in the context of how much of the skin is involved. It doesn't mean that there is a limited amount of organs being involved, or diffuse meaning all the organs being involved. No, not really. You can have internal organ involvement in patients with limited skin involvement. You can have internal organ involvement in patients with diffuse skin involvement. So the limited and diffuse terms pertain to amount of skin being affected. A few facts that people may want to know from what we know based on projected numbers. If we compare and look at the current US population of about 328 million, only about 300,000 have been projected to have scleroderma. Now, this number might be a bit more, as the statistics is based on some epidemiological studies that were done many years ago. Of this 300,000, only about 80 to 100,000 truly have systemic form of scleroderma. In other words, the others have a localized scleroderma. The age range usually is in the range of 25 to 55. And the key part is the fact that this is commonly in this age range. We have seen patients on either side of the spectrum. In other words, I have some patients who have juvenile onset or pediatric onset systemic scleroderma. I also have patients in their 80s who've had a new scleroderma presentation. Now, those are kind of exceptions. We don't see that quite commonly. The age range is commonly 25 to 55. Tends to affect the Caucasians more than other ethnicities. However, when it affects African Americans, especially men, it tends to carry a bit of a worse prognosis. So all the more important to catch it early and step in early in terms of treatment. And also tends to be common in women more than men. And again, this is a reminder of where we use the limited and the diffuse terms. It's extent of skin involvement, and there's no involvement of the internal, not the involvement of internal organs. These are some pictures that, with consent from our patients in Michigan, that was published in a really well-written review of scleroderma by Professor Khanna and Professor Denton from the United Kingdom. Here are some pictures of a gentleman with diffuse form of skin involvement. On the face, there are face changes, almost making people look younger than their age because of the skin tightness that affects certain areas of the skin on the face. The hands are swollen, and it's not intentional that the hands are being flexed. They're really contractures. They're not able to straighten the fingers. On the legs and feet, those kind of reddish areas of involvement are where the skin is quite thick. And there's also some loss of hair in the lower part of the leg, which can happen in some patients. And picture D shows the contracture. So inability to straighten that elbow because of the tight skin involvement, not only affecting the elbows, but also the arms, because of which they can't straighten their arm there. Here are some examples of a limited form of skin involvement. Commonly, it tends to affect, as you can see, figure B, mainly the fingers, and then it progresses further. But here the involvement is confined to the fingers, wherein the fingers seem a bit puffy, and the skin on the back of the hands are really thin. You can actually see the veins of the skin, which usually you won't be able to see if the skin has gotten thickened. There are some red spots on the face on picture A. We call it telangiectasia. Many of our patients with limited form of skin involvement or CREST syndrome, or even with diffuse scleroderma, tend to have these red spots. They're usually harmless, but more of an annoyance because people tend to just keep asking you, what are those spots in the face? And there are some capillary changes that can be seen even without the need for a microscope around the nails, as shown by the black arrow in picture C. I just wanted to share some photographs of how the hands and the fingers and the skin look like in these different subsets of scleroderma. Now, in terms of organ involvement, there's a whole list. Obviously, for this talk, I have marked the kidneys, and I'm going to be talking about it, specifically about renal crisis. But beyond the skin, in terms of blood vessels, there's Raynaud's. There's also high blood pressure in the lungs, what we call pulmonary hypertension. In the lungs, there could be scarring of the lungs or lung fibrosis. There can be fluid accumulation around the heart, and rarely involvement of the heart muscle. And GI involvement or the gastrointestinal involvement can be not only patchy, but entire spectrum from the mouth to the rectum can be affected in a very patchy form or in a very continuous form. Tends to be more intermittent or patchy. That's one of the problems, wherein it becomes hard to figure out the extent of the gastrointestinal involvement. And in terms of muscle and joint involvement, patients can have joint inflammation and contractures. Now, the timing of these different organ involvements has been described quite well, thanks to Professor Metzger at University of Pittsburgh, along with Dr. Steen, who did a great job with their natural history studies in patients with scleroderma. Now, what you see on one axis is the skin thickness, and the y-axis is the disease duration. The skin thickness clearly seems to, let me just use a pointer to help out. So as you can see, the skin thickness tends to peak quite early in patients with diffuse scleroderma, and over 3 to 5 years, it tends to slowly plateau and maybe digress or regress a bit. It never comes back to normal. The internal organ involvements, when they happen, tend to happen early on in patients with diffuse scleroderma. Usually within the first year or two is where we tend to see it. Now, specific to this talk, the kidney involvement also tends to happen very early on in patients with diffuse scleroderma. And it's been described that kidney involvement tends to almost exclusively happen in patients with diffuse scleroderma. There are exceptions, though. I have seen it in patients with limited scleroderma. I've also seen in a very rare situation when patients presented with kidney involvement as the main manifestation and never really developed much of skin involvement. We call it cine scleroderma, but that can be quite challenging to pick up. Compared to that, in patients with limited form of skin involvement, the skin scores never peak too high, and they tend to gradually kind of plateau after some time, but the skin thickness is never as high as what happens with diffuse scleroderma. Now, usually pulmonary arterial hypertension, or PAH, high blood pressure in the lungs, tend to be later complications in scleroderma. That's why when your rheumatologist says, please get your echocardiogram or lung function test year after year, it's really to see if patients are developing any manifestations of pulmonary hypertension. Now let's come to the topic of discussion today, what to expect with kidney involvement in scleroderma. And for that, I kind of just put this solid line to differentiate before and after what to expect. So before the kidneys get involved, often blood pressure is normal, and standard blood tests for both blood and urine, a standard test for both using the blood and the urine for assessing the kidney function tend to be normal. So creatinine, and no blood in the urine, no proteins in the urine. That's exactly what we expect and continue to watch. When kidneys do get affected in the most severe form, which is what we call scleroderma renal crisis, it is truly a crisis because there's often a very rapid onset of high blood pressure. Patients often don't have any symptoms initially. When they do have symptoms, it's probably because the blood pressure has been high for many days or weeks that has gone unrecognized. And the symptoms could vary from getting headache, having blurred vision, or having chest pain, or just not feeling right. And all those symptoms can happen in people with high blood pressure. If high blood pressure is not promptly recognized, then, as I said, the symptoms start coming in, and the kidneys start developing damage, and the blood tests start to become abnormal pertaining to the kidney function. But there are other blood tests that can become abnormal. Patients can become anemic. There could be damage to the blood cells causing both anemia and low platelets. There could be an accelerated form of clotting, and there could also be widespread blood vessel injury. Now, most of these are microscopic. It's not, the words I use and the terms I use here can look and sound quite graphic, but it's all microscopic when it happens. And from a patient standpoint, all they might be feeling is just tiredness. I just don't feel right when the symptoms do come in. And when we identified it as a true emergency, we certainly take it very, very seriously, and we are very aggressive in starting the workup and the treatment that is needed. But the question is, between me being normal and between getting scleroderma or renal crisis, is there anything in between these two extremes? In people with scleroderma, they did a longitudinal study and looked at, is there a gradual decline in kidney function that happens like with some patients who have diabetes or some patients who have high blood pressure for a long period of time? Generally, that kind of a pattern is less likely. If at all it happens, the decline in the kidney function is really mild. Often when that does happen, it's in the context of patients with scleroderma who also have diabetes and high blood pressure. And the decline that tends to happen in between these two extremes tends not to be progressive. And it does not predict the onset of renal crisis. What do I mean by that? So say I have some patients who say I have diabetes. My kidney numbers have been gradually getting worse in the past year and a half, wherein the creatinine increased by maybe 15 to 20%. And now I have a new diagnosis of scleroderma, or I had scleroderma for the past 6 months. Is this worsening in the kidney function because I'm developing a renal crisis? Less likely. That's not the case. That isn't how the kidney involvement presents in scleroderma. When it does happen, it's really sudden. So we need to identify who gets it, what are the risk factors, and how can we advise our patients to help identify this pattern. That's the main focus of this talk. So the questions often asked is, how common is scleroderma renal crisis? It's pretty rare, so I don't want to scare people by saying that it's common. It's quite rare. It's anywhere from 5 to 15%. It's quite a wide range presented there in terms of how often it occurs. It could be less than that, but it's not as common as anybody thinks, and is really not to be worried of as long as you know what to look out for. What blood pressure value should I be worried about? The key thing is a new onset, often symptomatic hypertension. In other words, a new onset of high blood pressure, especially with symptoms, should make you think about kidney involvement starting to occur. But the more important thing I tell my patients is, please know your baseline trends of blood pressure. Maybe for the first month or so, check it every few days a week, just so that you know what's the range of your top number and bottom number. If there is a 30 millimeter or more increase in the top number from baseline, that is something that you need to get attention, get checked out. Same thing, if all of a sudden there is a new blood pressure increase of over 140 over 90, we consider that to be something that needs attention at that point. But there are unanswered questions that to this date unanswered. What are the triggers? Why does the blood pressure shoot up suddenly? We don't know that. Why does it happen? We just don't know that. And there is a lot of attention and work being put in to that realm also. I included a couple of pictures just to show what happens to the circulation, the blood vessels in the kidneys. This is an arteriogram, and on the left is figure A and the right is figure B. In figure A, the kidney circulation is regularly distributed, and you see the branching of these blood vessels. They become smaller and smaller and smaller, like the branches of a tree. So it's pretty, you can think of it as a pretty dense tree with lots of tree branches. In comparison, look at the picture B. It seems that there are some hollow spots. The kidney circulation shows there's an extensive loss of these smaller blood vessels when associated with scleroderma renal crisis. That just gives you an idea how much the circulation can be affected when the renal crisis occurs. Now, what happens at a microscopic level? These are small sections of the kidney that is seen under the microscope after they're stained. This circular thing is what we call an artery. An artery is a kind of blood vessel. And in a patient with scleroderma renal crisis, there is formation of clot in the center, the lumen of the artery. That's what we tend to see. And there's usually surrounding damage in the adjacent kidney cells due to lack of blood supply from the clot. So that's one presentation. The second thing that we can see is the same artery, the walls of that blood vessel is really thickened. We call it the onion skin lesion because it's almost like the layers of an onion peel. And the lumen, again, the center part through which the blood flows, becomes really narrow. We call it a pinpoint lumen that can happen. So just for comparison, I just pulled out a picture of the onion peel, and this pretty much looks like that. It's onion skin, it's in layers, and then there is the lumen here that's really narrow. So then the question is, if this is the case, then what are the risk factors for a renal crisis? Are there features in a particular group of patients that we need to be aware of? Now, let's remind ourselves the previous statement that I made, that systemic scleroderma is a family of conditions. In other words, you can't quite apply the same rules to everybody. You can think of us all as a basket of different kinds of apples. Some may be Granny Smith, some may be Fiji. So there are different features or characteristics, or sometimes it could be apples and oranges. Someone might just have a very, very limited form of systemic scleroderma that's barely symptomatic. And on the other hand, you have people with a very severe form. So with that statement, some risk factors that have been associated with renal crisis include a specific type of a protein that can be present in the initial part of your testing for scleroderma. It's called anti-RNA polymerase 3 antibodies. This has a very strong association for renal crisis, and we are particularly careful in patients who have RNA polymerase 3 in being proactive in monitoring their blood pressure. Second, if patients have diffuse form of skin involvement and they also have tendon friction rubs, which means that when we make them move their wrists or their hands and feel the joints or the elbows or the shoulders, it almost feels like a stretchy, cracky feel wherein the surfaces of the tendons can get stretched, and that can actually be felt more than heard. And that's called tendon friction rubs, and that's been associated with renal crisis. Again, a diffuse scleroderma patient with joint inflammation. And the fourth and one of the most important things is the dose-dependent effect of steroids. Now, you all may have heard variably that doctors are a bit hesitant. Your rheumatologist is a bit hesitant to put you on steroids or prednisone because of scleroderma. The reason that is the case is at doses of prednisone over 15 milligrams, there is a risk of renal crisis, especially in patients who have these additional risk factors for renal crisis. So our general trend is, if we really need to put anybody on prednisone, we try to keep it below 10 milligrams because there is a direct dose-dependent effect on precipitating or triggering a renal crisis. Okay, now we know who has higher risk, what are the risk factors, who are the subsets of patients who could develop renal crisis, and how does it present. So we know that information. The question that's important is, how do we recognize it? How can we recognize it early? And how should we treat it? And what is in your control? Timing is everything in scleroderma renal crisis. Early recognition, especially in patients with risk factors, can make a difference. So it is important to know your risk factors pertaining to developing renal crisis. Now, the presence of these risk factors does not mean that a patient or a person will develop renal crisis. So please don't get me wrong. So if we go back to the previous slide, just because someone has these set of risk factors, it's not a proven thing that they will get renal crisis altogether. However, being aware of it and being watchful certainly helps. So we often tell our patients, please buy a blood pressure monitoring device that way you can monitor your blood pressure at home. It is both time and cost effective. I usually tell my patients to get an early morning blood pressure and keep a log with them. And then it's usually quite self-informative in the way that it helps in knowing what is my trend of blood pressures and when can I recognize if it's going away from its usual trend. And that's where it becomes an important step from a self-management standpoint. But once identified, what next? The high blood pressure should be treated promptly and aggressively. So call your rheumatologist or a primary care physician, clarify whether you need to go to the ER. That's if you're not having any symptoms. But if you have symptoms, if you're just not feeling right and there is high blood pressure, seek care in the ER and tell the ER physician about your concern for scleroderma renal crisis, because that is probably not the first thing that would come on top of anybody's mind unless you actually say that I have scleroderma and I'm concerned about scleroderma renal crisis. And that's the reason I came to the ER. It's also helpful if you go to your physician or the ER to have a log of your blood pressures, at least in the past week or 2 weeks. That way they know that this is a trend that it usually is. How is the high blood pressure managed? The first choice of antihypertensive agents are something called ACE inhibitors or angiotensin converting enzyme inhibitors. Often some patients, especially those who need hospitalization, may need more than one type of antihypertensive. And if the blood pressure can be promptly and completely controlled in a matter of a few days, the kidney injury can be prevented. But if the kidneys are affected with persistent management of the blood pressure, over time, the kidney functions actually can improve. Now, that's a big deal. The reason I say that is there is a percentage of patients who may need dialysis when they have scleroderma renal crisis. For some, the duration for which they need dialysis is limited and the kidney function starts improving so that they don't need dialysis and gradually comes to a much lower number. For people who continue to need dialysis or the kidney function continues to worsen even after 6 months of renal crisis, then we really urge for consideration for a kidney transplantation. All these are people who need dialysis for the longer term, people who need kidney transplantation. That's a very small percentage of patients who get scleroderma renal crisis. But the key thing is early identification. Early identification, seeking care early, getting treatment early. Those things are important.
Is there anything, doctor, that our patients can do to try to help their health, their overall health? I know we talk about diets and exercise, but is there particularly one or two or three things that we can point to help our patients be able to manage and control their high blood pressure?
Absolutely. I think there are 3 to 4 key things that are important. The first thing that, as I said, is if you know the risk factors, important to monitor your blood pressure, keep a log and know your trends of blood pressure. That's the only way you can pick it up early. The second is eat on time, sleep on time. It's a simple thing, but often ignored due to our day-to-day routines. Eating on time, especially smaller amounts of food, kind of spread out through the day, and having the last meal of the day at least 3 to 4 hours before you go to bed, and sticking to that routine is very important. Same thing is with sleep. Mindfulness activities are very helpful in keeping the stress levels down. The mindfulness activity could be gardening for somebody. It could be doing their household chores, or it could be working in their garage, or it could be meditation, yoga, any of this, whatever you feel your mind can relax doing that activity, that's going to be an important part of your life. And those are some of the key things in just self-management and keeping track of stuff. Now, despite all this, I have had patients who don't have any stressors, and or they're not really so stressed out and still have high blood pressure. There is nothing apart from seeking care at that point. You certainly do need to take that seriously. You don't want to assume that it's if someone has high blood pressure and their blood pressure continues to be high, and it's not from scleroderma because they have the high blood pressure even before their diagnosis of scleroderma, I usually tell my patients, please don't presume that it's your high blood pressure that's being uncontrolled. We really don't want any presumptions, because treating is far more beneficial than taking the risk of not treating.
Okay, thank you.
Now, a bit of a fact about ACE inhibitors. These are uniquely effective in renal crisis. Back in the 1960s and the 1970s, scleroderma renal crisis was the first and the foremost cause of death in patients with scleroderma. When someone had scleroderma renal crisis, there was nothing that could be done beyond trying our best, and patients would just die. It was quite fatal. Since the ACE inhibitors came on in 1990s, it really revolutionized the way we treat, to the point that some of our patients, we treat them on an outpatient basis. We don't have to have all of them getting hospitalized just because of these medications. And 60 to 70, if not 80% of patients can be treated successfully without causing any kidney injury or reversing their previous kidney injury. This is a big deal. So we often say this is really the first line of treatment if someone is suspected to have scleroderma renal crisis. But we also tell our primary physicians or ER physicians to not stop there. If the blood pressure is not improving, to add on other appropriate medications to help manage blood pressure. Now, someone might ask, if that is the case, and if I have risk factors, why don't you just put me on this medicine? Maybe it'll prevent me from getting a renal crisis. Maybe it'll prevent me from getting kidney disease. In fact, that's been shown to cause more harm. In other words, you can't just use this medicine for preventative treatment. It can delay the presentation of renal crisis in some patients. In other words, if someone does develop a renal crisis, it's not going to show up as high blood pressure, but the kidneys can continue to be damaged. So usually we don't use it for preventative purposes. It's usually used only when the suspicion is high and for treatment purposes.
Excuse me, doctor. When I was 40 years old, I started blood pressure medication because I had high blood pressure. And I continued it through until I was diagnosed at the age of 55 by Dr. Khanna with diffuse. And one of the first things he immediately did was remove me from my high blood pressure medication, because it had actually been doing us good. And I actually was having low blood pressure. So that was one of the first things that he did, was take me off of that. And I watch it as a tool and use my portal. And just like you said earlier about the monitoring and all that, I mean, I went into that. I mean, I followed it strictly and all that, but I just wanted to point that out, that yes, I was on for 15 years on ACE inhibitors, and now I'm totally off them, and I do watch my blood pressure. So yes, it cannot be used as a preventative, as you just said. So yes.
Michael, thank you. That's a real kind of real life example that Michael shared with his story. That's really helpful.
Thank you.
Now, I do urge our audiences who have scleroderma to definitely look into the self-manage scleroderma.com website. It's an internet-based self-management program for our patients to help take charge of systemic sclerosis. And it's put together by many stakeholders, including Scleroderma Foundation. So to summarize, I do want to say that kidney involvement in scleroderma is rare, but does happen. When it does happen, it's quite dramatic. but it doesn't quite happen in everybody. There are certain risk factors that our patients need to be aware of. And there are things that you can do with a proactive engagement and conversation with your rheumatologist. If you are at risk, you should learn how to measure your blood pressure at home. Keep a log, keep a list of your readings, also share it with your rheumatologist, and certainly notify your rheumatologist when it's out of the normal, especially if it's going up high, both the top and the bottom numbers. Certain medications like high doses of steroids should be avoided. Non-steroidal anti-inflammatories are also advised to be avoided because they, when used for a long time, can affect the kidneys. So mainly the NSAIDs like Aleve, Advil, ibuprofen, naproxen, they can certainly affect the kidneys when used for long periods of time. And you should take caution with cold exposure as it may reduce the risk. So when you go out, especially people living in this part of the world, the Northern Hemisphere with scleroderma, please keep your core body warm, keep your hands warm, and you can be, you should just listen to your body. Whenever you feel that the Raynaud's comes on, whenever you feel that there are certain triggers or certain temperatures that's going to provoke or cause the Raynaud's attacks, just make sure you have a pair of gloves handy with you. I intentionally kept this for about 40 minutes so that I could take some questions. I can have some discussions here for our audience.
Well, I think it's real key that you mentioned earlier at the beginning of this presentation is you have to be your own advocate. And, you know, your last slide really brought that out, is that from the standpoint is that you're taking your own blood pressure. You're basically avoiding certain medicines. You're trying to reduce the risk of cold and the onset. And it's really saying, you know, it might be repetitive to our patients, to people who are affected by it, but really is that you have to do what you need to do to treat yourself, because just like anything else, you know your body the best. You are the one who is experiencing these symptoms and these conditions, and it's up to you to make sure that you correctly express that doctor, so your doctor understands what you are going through, what are the things that are happening to you, so that he can treat you properly.
I can't agree enough there, John. It's so important to be advocates of your own health here. And the more informed our people with scleroderma are, the better our physicians are going to be, the better our care providers are going to be.
And that's one of the things, like the people like Michael and our other patients who have scleroderma, is when they share it with the doctors and the universities, when they talk with new doctors on a yearly basis, so they get to see the scleroderma, you know, and ask the patient. So the new doctors who are coming on, like you said, it's a rare disease. It's not one that you see every day. And like you said, it's important that when they see the symptoms, the hands, the thinning and everything else, is that they're able not to jump to a conclusion, but make it part of a decision tree to determine whether or not scleroderma is an issue within that patient.
One thing that I wanted to add too is you spoke about ibuprofen, and as a scleroderma patient, I never had issues with ibuprofen. I do have with painkillers, and I had a surgery in 2017, and they just said just take Tylenol for it, or ibuprofen or Tylenol. I had ibuprofen, and for some reason that raised my blood pressure. So now it is listed as in my medicine as a reaction to it, because it not only raises my blood pressure dramatically, but I also get bloody noses, and I never had that reaction before taking ibuprofen. But recently too, I developed a wonderful thing with scleroderma. The gift that keeps on giving is scleroderma-induced gout. And I've been fighting it since August, and it was finally Dr. Kana that figured out it was gout. And we tried steroids for a while, and I hate steroids because I just don't like the effects of steroids on me personally, because I think it affects your brain and you can't sleep. But anyway, it didn't help. But I'm on 3 different anti-inflammatories. And the odd thing about that is my uric acid levels are low, but it's scleroderma induced. But I got to be very careful of it. But one thing too, you mentioned about the blood pressure is we encourage a lot of people in our advocacy that you carry a laminated card in your wallet that says if you're, like you happen to have to go to the ER, that alerts somebody that if my blood pressure is spiking, I may be going into renal crisis because I have scleroderma. It would help that process go a lot better. I also
So Michael, you make a good point there. I just want to kind of give a bit of a background to
certainly, please,
on the laminated card.
Yeah.
At the Michigan Medicine Scleroderma program, I think it was about 2.5 years ago or so, with the Scleroderma Foundation, and we developed a laminated card wherein we would identify patients who had risk factors and say that this is your baseline blood pressure reading and give it to them and put our name. And that's a way of having an alert, a med alert card in a way, as for scleroderma renal crisis. I think now there is a medical alert option that you could add to the Apple Health app or the Google Health app, wherein you can have it in the phone too, so that those technologies can certainly be used.
Excellent, excellent, excellent. I wanted to say too, I was invited to be part of a scleroderma presentation as an invited guest to the Central Pennsylvania Scleroderma Foundation support group. And I was asked because one of my friends that was the support group leader, he just celebrated his 2nd anniversary as a double lung transplant.
Oh,
and the first part of the was just their advocacy meeting. We had our guest speakers and that, but he asked anybody that wanted to stay on for that extra hour of the presentation, including me, because he had members of a support group that wanted to hear about his journey. And I stayed on for that full hour because he is currently going through kidney failure. And I never knew all this about lung transplants and all that, but he went into quite detail about the process. He got quite emotional, obviously, and his wife had to, fill in some of it. But right into the paperwork and going into this, they say right off the bat, there's a 25% chance that you will lose your kidney function going into a double lung transplant. He also said that half of those will never receive full kidney function. Unfortunately, with him, and he had to pass up his first double lung transplant because it was like less than a day after he was approved because he didn't have his affairs in order. But he got the next pair, and they did not know it until afterwards. But they had what came with the lungs was pneumonia. So he was on obviously steroids, every medication there was, which put him into renal crisis. And he does home monitoring now, or I guess dialysis now, but his next operation will be a kidney transplant. But he brought up a lot of things that I never knew. And I just wanted to say these because he said what his nephrologist, I guess is what they say, is the kidneys are the sacrificial organs of your body. He said that they're this is the way he put it. And I'm just asking because he said they're generally the first to give out because they're warriors. They're going to be the front line of defense. And that sometimes they come back and sometimes they don't. But it just was an interesting a way of presenting that, I thought. But anyway, like I said, it was just interesting to hear the differentiations of what causes and, the creatinine levels. I get my blood taken draws every 8 weeks because I am on CellCept. And with the technology, like you said, I can go in my portal. It's in my portal the next day, and it's a graph. I can follow everything completely, so I can self-advocate and keep my own stuff in line. So it's great. But I appreciate your having the presentation today. One last question I want to ask you: this is not renal related, but how often do you see a 20 to 23% improvement in one's pulmonary function tests that have interstitial lung disease and diffuse scleroderma?
In patients or people with scleroderma related interstitial lung disease, the practical expectation is that we try to prevent the progression of the lung disease. What that means is they may have a variable degree of impairment in their lung function. But when we identify that and decide to start treatment for their lung disease, our hope and expectation is to prevent that impairment from getting worse. Improvement is a rarity. We rarely see an actual improvement in the numbers on the lung function test. Now, there are few exceptions. The few exceptions are if there is a significant overlap of an inflammatory muscle disease, or what we call myositis. Myositis can be seen in some patients with scleroderma, but sometimes there could be completely coexistent autoimmune disease called myositis, or what we call idiopathic myositis, that can coexist with scleroderma. Now, myositis itself is a family of conditions. Myositis can be associated with involvement of the respiratory muscles and the diaphragm. So to make matters complicated, say you have a patient with scleroderma, they have lung involvement and they have myositis, and there is diaphragmatic and respiratory muscle involvement, then that can initially clearly show impairment in the lung function tests. But that impairment in the lung function tests, it will be hard to differentiate what is a component purely from the lung disease and what is a component purely from the muscle disease. Now, with treatment, the myositis improves, and there you see some of the lung function also improves. So that is the scenario wherein we could see some real improvements in the pulmonary function test numbers. But by and large, we are aiming for stability at this point with the current treatments available. That is not to say that we may not have treatments in the future that will reverse or improve the course of the disease. We just don't have it as yet.
I was just curious because when I was diagnosed and I had my first pulmonary function test at the University of Michigan in October of 2013, and after my last one in October of 20, yeah, I guess it was 20, the pulmonary, the lab technician that was giving the pulmonary function test, he said, "You just blew the best one ever." And so I looked at my graph, and my overall pulmonary function test since 2013 have improved overall 20 to 23%.
And part of it could be explained by the fact that patients who have diffuse skin involvement, because of the involvement of the skin of the chest, will also have restriction in being able to give their best in their lung function test. And over time, with the improvement of the skin, those numbers will certainly be impacted.
And that is exactly what I thought, because I always compared my breathing to I was wearing a wetsuit 2 sizes too small, or I was getting a bear hug and trying to breathe. And now my skin is not normal, but it's as close to normal. And so Dr. kind of, you know, he calls me one of his success stories, but I just wondered it because I understood that when you breathe and your lungs get any type of resistance, that they deflate. You can't. And what I was basically doing, I guess, it was panting rather than fully breathing. But I just saw that graph and I just did a like, wow, it was a very eye-opening that no wonder I can breathe easier. No wonder I don't get lightheaded the way I do. So I always do this in my advocacy to tell people that you can improve. There are ways that you can improve. So it's just taking action in your own advocacy of your own health. So thank you very much.
Well, doctor, I want to say thank you, but I think what you did today is reinforce the idea that scleroderma is a very ugly autoimmune disease. And as you talked about the one slide where we see the effects of the skin, the heart, the lungs, the pulmonary tract, now the kidneys, gastro. So it's not one thing or another with our patients that are affected. And it's very good because, as you mentioned at the start of this presentation, this is rarely talked about, and many of our patients are taken aback by that. So I want to say thank you very much for educating our patients and the caregivers so they understand what is going on, which is very important. So thank you.
Thank you for inviting me to give this talk, John and Michael, and to the Scleroderma Foundation. It's always nice to be a part of the community.
Michael, I will allow Michael to wrap this up. So from that standpoint, he has a few closing notes for this, and I will say thank you again, Doctor.
All right. I'd like to thank everyone, all of you for viewing this webinar. Staying educated about scleroderma is so important. This is the reason the Michigan chapter strategically has created web-based educational experiences. Being educated can help scleroderma community members become better healthcare advocates. I hope you'll join us for all educational webinars, and for more information, check out our website. This is all small letters, scleroderma.org/Michigan, or the National Scleroderma Foundation weekly e-letter that is delivered to your mail every Friday. Thank you again, Dr. Nagaraja, for presenting today. And the next time that I'm down there, if I am allowed inpatient visits, I'll look you up and say hi again. But
Sure.
Thank you very much, sir. I
Yep.
appreciate you. You're a wonderful, wonderful attribute to Michigan medicine. Thank you very much.
Thank you.
Thank you much.
Bye.
Bye-bye.